Shall we go start?
We are live now, ma'am.
Yeah, thanks.
So good evening, everybody.
Yeah. Good evening to one and all, and very good afternoon to our esteemed speakers from England, Dr. Joe Mountfield and Dr. Sanjay Rao and Dr. Susan Ward. Today's evening meeting is an initiative of the IRC RCOG India South Zone, and I extend a very warm welcome to our esteemed chairpersons, Dr. Bhaskar Pal and Dr. Uma Ram, and to our invited speakers from England. So we are looking forward to having a very fruitful discussion with you. Today we have three topics. One is differential attainment, which I'm sure is a very new word to many of us, and medical training initiative scheme, and also the MRCOG exam update. So I now invite our chairpersons, Dr. Bhaskar Pal and Dr. Uma Ram. Dr. Bhaskar Pal is our dynamic AICC RCOG chair, and he's also the vice president of IAGE and president of the West Bengal Obs and Gynae Society. Welcome, Dr. Bhaskar Pal. And Dr. Uma Ram, she's currently the chair of the IRC India South Zone and the treasurer of ATN RCOG. She's director, Sitapati Clinic and Hospital, and consultant obstetrician and gynecologist. Her special interest is high-risk pregnancies, gestational diabetes, twin pregnancies, and IUGR. Over to Dr. Bhaskar Pal and Dr. Uma Ram.
Thank you, Dr. Deepa. And at the outset, I would thank the UMA and the entire team at South Zone for inviting me to chair this session. Although this session would be of immense importance to trainees and trainers in terms of where we stand in as far as the MRCOG exams are concerned and MTI scheme is concerned, there is something new for us to learn also, and we are eagerly waiting to hear about differential attainment. Without wasting any time, Uma, may I request you to introduce Ms. Joe Mountfield, please.
Thank you very much, Bhaskar. It's my pleasure to introduce Joe Mountfield, and this is a program that we've been talking about for a few months now, and Joe has kindly agreed to do this talk for us. She is the Vice President for Workforce and Professionalism of the RCOG and is a consultant obstetrician at Southampton, has done a lot of work in the field of education, and has a lot of commitment and interest towards education and workforce behavior, and therefore is somebody that I'm sure will do a very, very good talk to introducing us to the concept of differential attainment, and also talk a little bit about mentoring. Over to you, Joe.
Thank you. I'm absolutely delighted to be here this evening. I'm going to try and share my screen because then I can start concentrating properly, because it's always the most stressful bit, making sure that it works. Has that come up okay? Yeah. And I'm going to try and put it into slideshow.
Yeah, we can see it, Joe.
Perfect. I can't see it yet, but I'm going to start talking in the hope that it's going to appear on my screen as well. There we go. It seems to be working. Excellent. So I am going to talk about differential attainment and what it means, but I am really conscious that the data, quite a bit of the data I'm going to present and what I'm going to say is really relevant to those people working in the UK. And what I'm going to try and do is talk about some of the issues around this, the concepts around this, and why there are I think, some really interesting messages for all of us, wherever we work across the world, about how we respect colleagues, how we try and sponsor and support people so that we can move to a place where we have a really diverse workforce, and that we can really cultivate the talents of a whole range of people who may not necessarily be the first people that you would look upon and say, we think you do really well in obstetrics and gynecology. And so this is about challenging some of our underlying assumptions about who we are and who should be doctors, about getting the best out of your team. And really also it's a bit about looking after yourself. So I hope it's going to be of interest. I'm going to try and make it as relevant to you as possible, and not make this a talk about something that's going on in the UK that we're trying to deal with. And so that's the bit about saying supporting those who are disadvantaged by our systems, because we do have, every system will have those that are, life is easier for, and those for whom it is not. I show you this picture because I don't know whether you've read this book. I'm hoping some of you have read it, because Adam Kay was a doctor in obstetrics and gynecology, and he gave up basically. And this is the book that he wrote about giving up. And it's really quite I found it quite a difficult read, although many people read it and fall about laughing, because it does have some really funny stories in it. But it really makes you, but what it does do is sort of document some of the quite challenging situations that we all have to deal with within obstetrics and gynecology. And then the thing that really pushed him, if you like, over the edge and made him leave both obstetrics and gynecology, but also then medicine, was a maternal death. And the way that he reacted to that, the support he did not get in that circumstances was sorry, my husband is just ringing me in the middle of this. That's just typical, isn't it? The support he didn't get meant that he left the profession. And he's, if you like, one of our most famous leavers. And so partly what I'm talking about is looking after people, and also thinking about how we can ensure that we don't have more people who leave simply, although there are no doubt complex reasons, simply because we're not looking after them as well. I just wanted to start with a bit of data that might be of interest. We know that quite a lot of our doctors are leaving training in obstetrics and gynecology. I don't know whether you know what your sort of rates of leaving are within your own area of work. Ours was up as high as 30%. I think it's less than that now. When we did this attrition project about 4 years ago, we were looking at rates of attrition of around 30%. And we wanted to find out why. And so we did a big project looking at asking trainees why they were leaving. And also then we did some focus groups about what might be the solutions for that. And I think some of what they told us plays into this whole business of differential attainment and what that is. You know, how we look after people within our teams, which is of key importance, and then retain them within the profession to be the high quality individuals that they could be. So, you know, the headline out of our survey was quite shocking, in that 79% of trainees had considered leaving the specialty at some point. Now, you may say that that's not surprising. At some point, maybe we all have our doubts. But 15% of the trainees considered leaving specialty training monthly or even more frequently, which is a huge number. And this was before the pandemic, I might point out. So these were worrying statistics for us. We also established that about nearly 90% of trainees have felt low in mood, depressed or anxious. And again, you may say, well, that's probably maybe even reflective of the population. But again, nearly 20% of trainees were feeling these feelings monthly or more frequently. And if you look at the numbers that were requiring treatment in terms of formal talking therapies, cognitive behavioural therapies, or mediation, there are quite significant numbers of trainees requiring quite extensive support because of the challenges of the job. And as I say, these were before COVID. So there are definitely some issues here about how the numbers that are leaving and how we're supporting people. And some of that was around where they were working. They didn't like the hospital they were working. They wanted to work somewhere else. And some of it was about the training program themselves. And actually, they quite thought that they might like to go and stay in a particular area and take a standalone post. So interesting stuff. I'm not going to say anything more about that. There's a few acknowledgements there that I just wanted to make to the people involved, because there was a lot of work went into that. I now want to talk a bit more about differential attainment, and I'm going to start with the exams, and I'm not going to go through all this data in a huge amount of detail, because as I say, it is relevant to the UK and to obstetrics and gynecology, but I think you will find it of interest, because it does involve a whole pile of data around gender, around whether you work full-time, and also whether you're from an ethnic minority, as to how successful you are within the profession. And this is exam pass rates. And so this will be of interest, and it will feed into what Sue is saying. If you look at these pass rates for candidates by gender and age, you will see that overwhelmingly women do better than men, generally speaking. There's some equality. At the bottom, the age 20 to 24, there are very, very small numbers, because most people do not do our specialty exams, as I'm sure you're aware. Part 1 and Part 2 and Part 3 are not done by people of that age, because they're still in medical school mostly, or in foundation. So if you look then further up, as the age goes up, you will see that women generally do better, and the older you get, the less you are likely you are to pass the exam. So age, so if you're over 45 and you're a man, you've got a pretty low pass rate for our exams, basically. If you work less than full-time or full-time, interestingly, it seems there is very little difference between whether you are a less than full-time trainee. So sometimes there is a perception that if you're not really committed to your career and not working well, you won't do as well in your exams. This doesn't seem to bear fruit. There is another really interesting statistic here, which is about deprivation quintile. So this looks at, so the GMC did this by looking at the postcodes of where trainees came from, where their background was before they went to university, basically, and they've got that data. And then they followed that through to say whether you lived in a more deprived area or at least or not a deprived area. And again, you can see that if you are live in a more deprived area, you will not do as well in your exam as if you are from a more affluent. If you look at ethnic groups, again, there is real disparity here between white and BME individuals. And you can see the striking differences, whether your primary qualification was in the UK, was in the EU, or whether you were an international medical graduate, and therefore your success rate, your pass rates, again, improve as you. I'm really sorry, I'm very distracted because somebody's hammering on my front door. This is just typical that this this happens. So moving on to the next slide, basically, and I'm not going to go. This looks now at the progression through training. As you will be aware, we do yearly. I hope you'll be aware. We have our yearly progression through training, and again we look at the outcomes as to see whether your gender makes a difference in terms of your success, and what your ethnicity is. And again, there is some disparity in these graphs. All of this data comes from the GMC, basically. So you are more likely to get a unsatisfactory outcome if you are male than you are female. You can see that on this particular graph. And there is the less than full-time men, interestingly, don't do as well as the less than full-time women. Again, there is some difference by deprivation quintiles in terms of outcomes, although not as striking. And certainly there is some difference. I'm really sorry. I'm getting very. My doorbell has gone 5 times now, and I'm going to have to just go for 1 second to please tell them to go away. I'm very, very, very sorry. I'm sorry. I'm doing a presentation to India, and I've got. Oh, God. I've got about 50 people listening to me talking. I'm really sorry. I'm sorry about that. I'm sorry, but I couldn't ignore it. They kept hammering on the door. Oh dear, oh dear. Right. I breathe. Differential attainment. So differential attainments is the difference between the average attainment of one group of trainees and the average attainment of another. So, and as I've just shown you in this data, the most striking difference in our data is between white trainees compared with trainees from an ethnic minority, between male and female, and between deprivation and social class. This is you can Google this and it comes up, and this was a really, really good program about this. And this is a commentary on our class system within the UK. And so Amal Rajan, that if any of you listen to the BBC, you may have heard him. He's quite well known now across the BBC in terms of journalists, and he's second generation Indian. He went to Cambridge, has got a really successful career. And he did a really, really interesting program about students who'd done extremely well in university and education, but how they could get into some of the elite professions. And those were banking and journalism, television and journalism. And what was really what was really striking about this was, although these individuals actually had done extremely well through their education and got top class degrees, they really struggled to break into these particular industries. And this plays through basically to medicine as well. And so if you look at the effects of class within this country, 6% of doctors are working class versus 33% of the working population. And basically, there's some great research by Sam Freeman at the London School of Economics that shows that actually there is a 16% class pay gap. So if you're in the same job, but you are from a working class background rather from a privileged background, you are likely to be paid 16% less. And for women, it was much higher, 19%. So it's even worse if you're a woman. And if you're from a BME background, especially if you're a woman, the differential is quite staggering in terms of your achievements during your career. And if you account for the fact that this is not due to the education, so your education is the same, you've actually had the same amount of training, and they looked at all these confounding factors, the number of hours that are worked or their experience, it's still, and you account for that, there is still an 8% gap in pay. And that is all about that does not seem to be a reasonable thing to happen within people's careers, that simply because if you come from a different background, that you should be paid significantly more. And what was the reasons they felt was the difference, why people from a different background, from an upper class background, did better than working class? And this was about sponsorship. And so I want to say a little bit more about sponsorship. This is looking at the people who help people through their careers. They sponsor them through their careers, help them to achieve more. And why do they do that? Because actually they fit into the club, if you want to call it that. They fit the mold. They know what to say. They know who the people that they need to meet. They know how to interact with those people in a way that you're not taught if you're from a different background. And I think all this stuff is really fascinating for us when we consider who comes through into medicine. So why does this differential attainment exist? I've talked a bit about sponsorship, but the GMC have done quite a lot of work around this now. And it's really, it's still not 100% clear why there's such disparity between some individuals, especially between different ethnic backgrounds and different gender, but they're likely to operate at different levels. So some of it is at the individual level, some of it is at an institutional level, and some of it is all about policy and society. So if we think about the exams, so could we ask ourselves, is the reason why that actually there's a lower pass rate in men, or there's a lower pass rate if you're from an ethnic background, is it because of overt discrimination, or potentially, or is it unconscious bias? And these are really interesting questions. Sue will tell you that all the examiners for the IRCOG have to do some training around unconscious bias to try and help people recognise that we all have preferences, and we all like people who are like us and get on with them. And but there is also evidence that actually unconscious bias training actually isn't terribly effective.
Power off.
Can you still hear me?
Yes, Joe, we can.
Yes,
Hello?
we can. We can hear you.
Hello? Oh dear.
We can hear you.
I'm hoping you can you still hear me?
Yes, we can.
Joe, we can hear you.
Hello?
We can hear you.
Please continue. Right. Okay. I've just seen that now. So sorry. This is turning into a particular farce, isn't it? I don't think my screen is sharing now, though, is it? We can hear you. Thank you. Can you see my slides?
Power on.
You need to reshare. Okay. Thank you. Oh, dear. Is that working or not? No. Oh dear, oh dear. Right, share screen. Let me try again. Okay, so I'm going to carry on. So, differential attainment. So it's unlikely that differential is due to a deficit model. So it's not that actually some individuals are just not as good as others. It's far more complicated than that. And the GMC research tend to suggest that it's the learning environment and the relationships within it that have the effects on the individuals that can lead to this change in attainment. And so what does the research and the evidence tell us about why some people do better than others in a systematic way? And some of this is about problematic relationships with seniors. There's a lack of trust and support within certain individuals. Within the UK, and particularly around the BME, from AME trainees, there is a perceived bias around both within recruitment and also in getting people to assess them so they can make progress within their training. And then there is also a lack of support in and outside work. So some of this is about the learning environment, but it is also for some individuals who come work in the UK and move to remote areas in order to get their training, but then are lacking in support, which outside of work as well, which does have an impact on their progress. So you'll know that the college has set up a race equality task force, and we have 3 streams. Eddie's chairing the stream that's looking at what's happening within the college. Christine McKetch is chairing a stream around health outcomes for women, because we also know that health outcomes for women from different ethnic backgrounds is not as good as for white women. And Ranai Thakkar, I'm sure who many of you know well, is chairing the work stream, which I'm part of, which is looking at career progression, training, and the sorts of issues that I'm talking about today. I come back to unconscious bias because we all have a degree of unconscious bias, and one of my favourite TED Talks around this, which I would encourage you to use if you ever want to talk about this to anybody or to look at yourself, is a TED Talk by Yasmin Abdul Majid around what does my headscarf mean to you. Really powerfully portrayed a woman who's actually a highly achieving engineer, and she does a very good talk about how appearing with a headscarf on in certain situations means that there are a number of assumptions made about her before she's even opened her mouth. It's a really telling TED Talk, and I would encourage you to have a look. This is something personal from me. I'm a bit of a Barack Obama fan, and for me, when I started looking at these sorts of issues, this was one of the books that I think really changed my perspective on how what it must be like to be. I've got plenty of experience personally as how gender can impact on your career progression, and I can tell you many stories from my career about people not, shall we say, being as positive about being a woman in obstetrics and gynecology. But I clearly have no at all insight into what it's like not being white. And I think for me, this is the book that helped me understand more than anything else what it must feel like, as he puts it, to live in a white man's world. And I've got a huge amount of respect for Barack Obama. And I think, and for the first time, having read that book, I felt I could at least start to empathize with what that experience felt like. Because if somebody is talented and successful, and somebody who became the president of the United States could speak in that way, then it did have a really big impact on me and my experience of what it is to be white in this world compared to what it is to be a person of colour. The other thing I wanted to mention is this concept of resilience, and this is about, you know, if you're not doing very well in work, isn't it all about how resilient you are? And basically, if we just taught people to be resilient, they'd all do terribly well. But I think it's far more complicated than that, and resilience isn't innate. And this really interesting piece of research suggests that actually it's a dynamic. Resilience is actually dynamics, and it's context dependent. And so if you look at somebody that's got in a situation where everything's going well, there's no or low risk basically, and they are a relatively stable and resilient person, they will have a good outcome if because life is going along quite well. But if you have a risk, and that risk may be an adverse outcome, so you do experience something like a maternal death, whether or not you actually recover from that basically will depend on whether you have protective processes that are helping you to overcome that, or whether actually there's a whole series of things that means that you spiral downwards and you get to a bad outcome. And that may change depending on where you were, what's going on in your personal life at the time, a whole pile of different things that interact with that. So resilience is not a fixed concept, it's not something that you are born with. It is something that you require, but it is something that we can all build within the people we work with by ensuring if there are things that happen that we help them with those protective processes. And these, if you're talking about people that we're training, these are the things that might help trainees be resilient in the face of those risks. And the first of those is called stealing. And this is about exposure to the challenging situations. We all have to learn to deal with difficult situations in obstetrics and gynecology. It goes with the job. But it's about enabling them to be exposed to those challenging situations, but with support and feedback about what's gone well, about what things may need to change next time, etc. And it's with the support, but also with the genuine feedback. There is also something about a sense of belonging and self-worth that's really fundamental to whether you actually can be resilient in the face of risk, and about autonomy. Personal relationships are really, really important in this. And the thing about self-complexity is about how you define yourself. If you define yourself solely within one role or one relationship, then that makes you more vulnerable when things don't go well. Whereas if you have a number of roles and a number of and many different relationships in and outside work, that is a protective mechanism. So these are interesting concepts for us all to focus on, not just when we're thinking about differential attainment. This is around sponsorship, stealing and teaming. And I'm conscious I'm going over time, so I'll try and speed up a little bit. I'm not an Obama freak, but I do like this book as well, Becoming. I can recommend it to you. And the thing that really stood out for me is this story from Michelle Obama, where she went to Elizabeth Garrett Anderson School, which is a school within inner London. It's an all-girls school. 90% of the people in the school are from a non-white background, 20% were refugees, with 55 languages spoken. And she took a particular interest in a group of girls within that school. And the fact that she came, she talked to them. Some of them went back to the White House. She took some of them off to Oxford and Cambridge so they could see what they were able to achieve. The whole of that group, the whole of that class, increased their GCSE points by 2. So basically from a C to A in each subject across the board. And that was a genuine improvement when you compared it to the rest of London. And there's research was done by somebody in Bristol University to show it's actually a true effect. So this is a true effect of mentoring and sponsorship. And if you think, well, that's all very well, Joe, but that's just a book you're talking about, and Michelle Obama, we can't all be Michelle Obama. That's true, but there is also really good research to say that actually career success is largely a function of two important things. You have to work hard, and this was the same going back to what Amal Rajan was talking about and Sam Friedman was talking about in his research. Nobody is successful without working hard and actually having a degree of ability. But if you receive sponsorship on top of that, you are likely to do better in your career than if not. As I've already said, stealing is about support and feedback to increase resilience. But part of the problem about us giving feedback is that we actually think we've communicated when we haven't. And I love this quote from George Bernard Shaw on this point. And I think quality support for your trainees and for everybody working with you is about care and compassion. It's about thinking about if things have not gone well, what is the psychological first aid basically that we can put in? And TRIM is just one of those things. It's a thing that's been developed with the military, actually, that's been implemented in some parts of obstetrics and gynecology in the UK. And I can't emphasize enough how important it is that looking after each other, especially when things have not gone well, and COVID has brought that absolutely to the fore, is of such importance in terms of retaining and looking after your workforce well. So in our own attrition survey, 20% of the trainees said they wouldn't talk to anybody about leaving, which is a really sad indictment of our support within the profession. Teaming is the other bit that I think is really important about retaining people, helping them to achieve. And again, I can point you in the direction of Amy Edmondson. There's a lot on, if you go and search her on YouTube, you can see some of her fantastic talks about this. And psychological safety is about enabling people to feel they can talk about difficult issues, that they can be heard, and that they can explore what is of important of concern to them, basically. So it's about valuing conversations and talking about things and allowing people to ask the stupid questions rather than being discounted or criticised. And when you're talking about working together, we do have a tendency to be, the default orientation is about who did it. I need to convince them of my opinion, basically. We need to send a statement and we need to give people direction. And you know, we can use what we know to get an advantage. Whereas actually, if you really want to come together and do things more effectively, bringing in your whole team, you need to have a joint problem solving orientation rather than the default orientation, which is more about having a position and trying to convince others about it. So these were the key things that came out of our attrition survey, and I'm going to come back to that because I think for me, in trying to bring all these things together, it's about saying how do we help people be successful with their career, and therefore how do we stop them? Leaving? How do we enable them to be really successful? So, and the fundamental thing that came out of those sessions, those focus sessions, was it was about being valued as an individual. So all the quality support, having learning focused training, about having some flexibility about when you are working, about transparency and assessment processes were all really important. But in the heart of this was about being valued as an individual person with individual needs. So this is my final question to you all. How can you help improve and retain the best within the training sessions, training experiences that you have? Well, I would suggest that have a conversation about it. If it's something has caught your fancy from this conversation today, have a think about this. What can you and your team do to help improve the fact that some people within your organisation are probably not doing as well as others for a whole pile of reasons that I've alluded to around support, around sponsorship. And I would encourage you to think about sponsoring and mentoring somebody who's different from yourself, because then we're likely to diversify in our outlooks if we all try and think about not looking for somebody who's exactly like yourself. So invest time for your team and champion inclusivity. And I say this with a heartfelt, do not underestimate the value of tea and cake, because actually it cannot do wonders, basically. Quality support's really important, and please look after yourselves as well as looking after your colleagues. And my final suggestion is this: we are all leaders in this profession. You are all leaders in doing what you're doing. But leadership is not about being in charge. It's actually about taking care of those who are in your charge. And I love that quote from Simon Sinek as well. And that's my closing thought for you, with apologies to all the technical issues. I'm going to stop sharing now.
Thank you, Jo. That was an excellent talk. Jo, can you hear us?
Yeah, I can now. I'm really sorry about all that interruption in the middle of it.
That's fine.
Of it all.
Thank you so much. Though some of the delegates had felt this topic might not be relevant to our country, but after listening to you and a bit of introspection, I'm sure most will realize these problems of differential attainment do exist in our country based on gender and a different criteria, caste, religion, and social status. And we are also victim of this differential attainment within our country. I'm sure from your talk, we can take some cues and start working along those lines and implement the changes in our system. Thank you so much.
Thank you very much.
Can I ask a couple of questions while we are waiting for other questions to come through? Now, how do sensitize people as without political support when there is a gender bias, which is just not under your control, isn't it? So a lot of things is not under your control when you talk of differential attainment. How do you sensitize this without a political support, especially in a country like ours where the differential attainment is due to different criteria? Is there something as an individual we can do?
I think as an individual, it depends what, if you yourself feel that you are not having some bias against you, so you're not succeeding where you think you should be succeeding, and you're working your hardest and you can't work out why, then you need to go and find yourself a sponsor. So you need to go and find yourself somebody who can work with you to work out what you need to do in order to get the recognition that you need. Because that's all you can do as an individual, is find somebody who can give you some mentoring, who can talk you through what they think the issues are. They can't change society in the same ways that much as I would love to get rid of differential attainment and change it overnight within the UK. We can't. This is a slow process of societal change, trying to be more inclusive. So you as an individual can't make it all go away, but what you can do is go and think about who can I go and talk to, who may be able to steer me through the politics, if you like, so that at least I have the best chance of achieving my potential. And that from your own personal point of view, that's what I would suggest.
Right. And from the trainer's point of view, you've given us a lot of points as to how to look after the trainees. So thank you for that. The second question is, how do we get rid of this unconscious bias? We do have that quite an extent. I'm sure all of us have that. So I'm really not sure how to get rid of this unconscious bias. Is there any technique to that?
Yeah. It's not, I wish it was as easy as that. I suspect if I was a psychologist, they'd say years of therapy, but there we are. But so I think something is about being open to other ideas. As I said in my talk, the thing that changed my perception really about what it must be like not to be white in what Barrett calls a white person's world. I hadn't ever really got that. I thought I really understood it because I think I have definitely had gender bias, and Sue and I have exchanged conversations about some of the gender bias that we've also experienced as doctors within our profession. So that I get. but I didn't, I think it's something you don't experience yourself. It's really hard to put yourself in the shoes of others. And that's what it's about, putting yourself in the shoes of others. So I would say the only way that I like to think I've broadened my horizons, and don't get me wrong, it's not that I think that I'm completely without bias. I absolutely know I'm not without bias, because that's just being a human being. Is I read about other people's experiences, I listen to other people's experience, and I try to empathize in that. And I think that's the only way you can try and be more open-minded about it. But also recognizing that you'll never get rid of it, absolutely, because as I say, it's part of being a human being and the way you were brought up and all those things that influence you.
Thank you. Any other questions from anyone in the panel?
Bhaskar, you're muted, Bhaskar.
Listening to you, Joe, we actually were wondering what you could talk about. And the difference is that I think we haven't looked at it objectively from our point of view. But what are the points that you raised, the gender bias, and as Tamil Selvi raised, that while you have an issue with the bias between the white population and the BAME population, we have caste-based issues in India in many parts once you get outside the metros. We have all been brought up on a culture where we've learned that bullying and harassment is part of the day. You get resilient by being bullied and harassed by your seniors. And the unfortunate part is that most of the medical schools are extremely busy units. And we were actually, not only as far colleagues are concerned, we were taught not to be very supportive of people who couldn't cope. And we lost many people like that because they didn't succeed because we didn't have the time to hold their hands and say, okay, we'll take you along. It is a much more difficult situation, but yet I think it opens our eyes to look at it objectively. Of course, things have changed. People are becoming more supportive. And it is not, earlier it was a situation like, I've done an 84-hour week. How can people get away by doing a 48-hour week? Now they will not learn anything. I think people gradually are accepting that things need to get better for everybody. But I think you bring us to the track that we also need to look objectively how these cultures are prevailing and how they are preventing people from going ahead. And I think that was an eye-opening lecture for me, at least.
Good. I'm glad you enjoyed it.
Thank you very much. I think Ranjana, you had a question.
Yeah. So, Joe, it was a very enlightening talk. Really, lots of things which we hardly discuss. So they have been studied and there was evidence. So have you got any studies to compare your data with the other developed countries?
No, this is what I would call early. Even within the UK, the research around this has not been as fulsome as we would like, and I've not seen anything that looks at differential attainment comparing what's going on in the UK with other countries. And I think Bhaskar's point about should we be collecting some data within India to look at what's going on within our own system? Well, yeah, I would really encourage you to do that, because I'm a true believer that actually diversity gives you a stronger workforce, gives you a stronger team, because people bring different perspectives and different ideas into the workplace. And also, we're probably missing some really bright individuals that just never get a chance to come and contribute. So so that's my motivation. I want to make sure that we've got the best people who are really well supported, working in obstetrics and gynecology, looking after the women in the UK and around the world. And so if we can question ourselves about what's going on, that we're not really supporting everybody in the same way, that doesn't feel right. We wouldn't want different things for the women that we look after. We wouldn't say, right, Mrs. So-and-so from that over there, we're going to look after her much better than we are from this woman over here. I mean, that goes against the grain with all of us. We do our absolute utmost for every woman that we look after, and therefore it should be the same for the staff that we work with. But no, there isn't the data, Ranjana. I wish there was. When we maybe that's the next study we should all be part of.
Congratulations, you were the first one to bring out the data.
Thank you very much.
Yeah. So what
No,
do you
I
think?
think,
thank you.
Uma,
I think we should.
Okay.
Yeah.
All right. Okay.
Sorry. Yeah,
I'm
I'm just a little conscious of time, because
Sure.
this is definitely something that's going to make us all think, and hopefully, if we introspect and we are able to generate some information for ourselves, that would probably be baby steps taken in that direction for us. So thank you very much.
No, Uma, I had a small question.
Sure.
Joe, when you looked at the data of performance in exams and people going ahead, and you looked at it by race, did you stratify the data for international medical graduates and UK graduates?
Yes, it is stratified. So in fact, really interestingly, Bhaskar, that actually if you're from a BME background and you are, but you are been brought up and educated in the UK, you still do worse than the white graduates. So it is something about the systemic racism actually that sits within our system that means that even if you go through the same education, etc., you still will not do, you will still not achieve in the same way. And this comes back to, as I say, the education environment. But we haven't got all the answers. I tell you, I wish I had all the answers. Sue and I spend a lot of time thinking about this in our work stream, and we're trying to start to address that and raise the awareness of it and say, we really need to think carefully because it starts way back at school. It's not just they go through medical school foundation before they even get to us. So we're on a losing wicket before we've even got them. So yeah, it's really interesting, Bhaskar. It's really sad, quite honestly, and we need to do what we can to try and address it, because I feel really strongly it's not right that those sorts of that sort of differential exists in this day and age. Sorry,
Ranjana, do you want to quickly ask your question?
I said in the exam, you see, when I was interviewing candidates for the MTI, they were really good candidates, but the questions put to them, they were just not, familiar with the, so that also, leads to differential attainment. Yeah, right. Okay, thank you.
We'll leave Sanjay to answer that. Yeah, okay.
Okay.
So, Deepa, can we now move on to the next talk?
Yeah, can we have the next slide, please, Chitrakala?
Yeah, it's my pleasure to introduce Dr. Sanjay Rao, who's currently the RCOG MTI officer, and set up very tough targets for us in terms of interviews, what we need to do. He's a consultant obstetrician and gynecologist at the James Cook University Hospital in UK. Special interest in intrapartum care, benign gynecology, and postgraduate medical education. He's a training program director for the Northern Deanery and chair of the DRCOG subcommittee of the RCOG. And Sanjay would be speaking to us on MTI. Over to you, Sanjay.
Thank you very much, Bhaskar. That's very kind of you. So I will just share my screen. So can you see the screen, everyone?
Yes.
Yes, we can. You just need to be on slideshow.
Okay. Okay. So thank you, Bhaskar, and thanks everyone for inviting me for the presentation today. So my name is Sanjay Rao. I work as a consultant in obstetrics and gynecology at the James Cook University Hospital in Middlesbrough, which is a part of the Northern Deanery. And today I'll be talking on the RCOG MTI training program. I've also got my colleague, Dr. Jafar Shakir, who is a junior doctor in James Cook. And Jafar would just share his personal experiences, especially during the peak time of COVID pandemic when he was a junior doctor in ONG. So together we will be talking a little bit on the overall perspective of the MTI training program. So the RCOG MTI program is a 2-year program, and it is a highly popular program, much valued by international doctors. So it's a fantastic opportunity for many doctors who view this as a golden chance in their career to gain some experience in the UK, which gives them a broader view of the overall experience of working in the NHS, gaining some practice of evidence-based medicine, guidelines and protocols, and also completing the Part 2 and the Part 3 MRCOG examinations. And in some cases, they also get a chance to complete advanced training skills modules. So the MTI program itself is a part of the global health collaboration. And the main people who are currently involved in this program are Dr. Rani Thakur and Dr. Sue Ward, along with the MTI committee and with contribution from the SIAC. So the overarching objectives for the MTI program is that we would like a good collaboration with the MTI committee and the Global Health Committee. And the key persons who are in charge of the MTI program are Liz Russ, who is the person responsible for direct communication with the IRC chairs and also the day-to-day administration. And I must say that Liz has played a fantastic role in delivering her responsibilities in a very timely manner. Mr. Hiran Samaraj, he's the chair of the MTI committee, and along with this team, I lead the MTI office as an MTI officer. We are responsible for the recruitment and selection process for MTI doctors, which obviously is a very challenging process given the size of the whole program and collaborating with hospitals across the UK. So in terms of the responsibilities of the MTI committee itself, we are responsible for scoring application forms, which is a process led by a number of full-time consultants, substantive consultants who are working in the NHS and who realize what the clinical requirements and the training requirements of doctors working at the MTI program would best fit into the system. So they get an idea of how the CVs look and what the application scores should be like for a high-performing candidate. We now also have a virtual MTI interview process, which is a very significant process because it's led all across many countries, and we are relying very heavily on the contribution of the IRC chairs who have played a very significant part in conducting the interview in a fair manner and also ensuring that we have high levels of quality assurance. We would also want to directly support all the MTI doctors. So the MTI committee itself is constantly in touch with the MTI doctors whilst in the UK in the 2-year training program. And they also provide resources and signpost them for pastoral support. So we now have appointed MTI regional champions across the UK in different deaneries. So just for those of you who don't know, so the deanery is responsible for the postgraduate training, and they are linked with schools of obstetrics and gynecology in different areas across the UK and Scotland. And every deanery would be linked with a few hospitals, which could be large teaching hospitals, university hospitals, and even the smaller district general hospitals, so that the training program includes rotation in all of these hospitals. Now, I must point out that the MTI program is allocated to one hospital itself. So the MTI trainees do not rotate in other hospitals because the MTI process is still classed as a trust-led appointment, and the trust is directly collaborating with the RCOG to ensure that the recruitment process is fair and also that they have a contract of the 2-year program, and they take the overall responsibility to ensure that they're delivering the educational objectives of the 2-year program. We would like all the MTI doctors to feel more inclusive and much valued within the education program. So we're hoping that the MTI regional champions will help in collaborating, especially at the deanery level, at the level of schools, to make sure that they get a chance to attend all the postgraduate training sessions led by the schools. The other big goal is completion of Part 2 and Part 3 MRCOG examinations, and Sue Ward will talk about how best we can support them in terms of the Part 2 and Part 3 and what the overall performance of the candidates have been in the last few cohorts. So from a quality assurance point of view, how do we know that the MTI doctors are gaining what they need to achieve? So we have something called as annual review of competencies. And going forwards, this will be an annual process where we review the evidence recorded by the MTI doctors in the e-portfolio. And this is going to be in collaboration with the heads of school and the training program directors. And this is just one step forward for us to make sure that from a quality assurance point of view, the MTI doctors just don't feel that they're coming to the UK mainly for service provision without actually some training requirements being met. And we want a fair balance between both of these components. The other obvious big issues are workplace behavior. So like in every country, we do have problems with workplace behavior. So moving forwards, we have the RCOG-led initiative, which is to have workplace behavior champions. And across every deanery, we have a direct person who can be contacted in a very private and confidential manner to discuss any issues relating to workplace behavior. And we do take this matter quite seriously, and we have a zero tolerance for any cases of bullying and undermining. And this is something which we really want to stem. And if there's any such problem, it is highlighted through a number of channels. We also have equality and diversity issues. So every trainer has to complete mandatory courses in the context of equality and diversity. And Joe has obviously covered the issues of unconscious bias and differential attainment in a very excellent presentation just prior to this. So I would now like to highlight about what the MTI training matrix is. So if you visit the RCOG website, and if you go to the MTI section, we have the new training matrix, which has been updated recently in May 2021. And this matrix highlights what are the expectations in the 2-year program. And this could be at 6 months, at 1 year, at 18 months, and then again at 24 months. Because as you would appreciate, time flies very quickly. And at the end of the 2-year program, we do want to ensure that the MTI doctors have felt that it's been a positive experience and that they have achieved some exposure to evidence-based practice and also success in the Part 2 and Part 3 exams. Now, the e-portfolio is the single most important piece of evidence for all the assessments. So the e-portfolio is accessible through the RCOG website. So every MTI doctor would have a username and a password. And likewise, they're allocated educational supervisors. And they log in monthly ES meetings. So educational supervisor meetings are logged in to the portfolio as a matter of evidence. Now, we also have something called as an annual ES report, which takes into account all the evidence which has been accrued in the training year and whether it fulfills the requirements of the training matrix. Now, if an MTI doctor is not meeting the requirements, then discussions would take place with the college tutor and with the regional champions to see how best we could help them and help them achieve what the matrix requirements are. Now, some of you have already worked in the UK, so we know that the GMC is very meticulous and very strict about the requirements for annual appraisals and revalidation. So every doctor in the UK has to have an annual appraisal, and the evidence is recorded in the appraisal software. And every 5 years, they complete a revalidation cycle just to make sure that those doctors have the relevant knowledge, skills, and they have a safe patient approach, and that they're able to conform to practice within the guidelines and protocols, and that they also recognize where things are wrong and take appropriate actions. So that is the overall requirement of fulfilling an appraisal portfolio. And again, this is like an ARCP for consultants. And for the MTI doctors, the appraisal process is trust-led, and the medical director of the trust is called as the responsible officer, who informs the GMC about the safety and the approval for license for this doctor. So I'll now come to some work-based assessment tools. And I appreciate that for those who are working abroad, this may be a bit difficult to understand. So please stop me if you have to ask questions. So for every MTI doctor, we have a number of work-based assessment tools, and these tools are for all trainees, postgraduate doctors working in the UK. And if we access the e-portfolio, they can generate what is called as a ticket. So to cite an example for a case-based discussion, if a trainee has attended an obstetric medicine clinic, and if there's a complex case of diabetes, and the trainee has taken a thorough history and gone back and read Catherine Nelson Piercy, for example, and understood the management of type 1 or type 2 diabetes or GDM, then they can send a case-based discussion to the consultant trainer within 2 weeks. And there would be some learning outcomes which the trainee has to identify, and the consultant has to complete the ticket which has been generated through the e-portfolio. So that is how case-based discussions work. And again, this is a trainee-led process. We do not want to spoon-feed MTI doctors. We want them to go back and reflect on guidelines. So all guidelines can be accessed on internet and through local hospitals through their own intranet. And they can also read the standard textbooks of obstetric medicine or whatever specialty they are focusing on. So another example of a case-based discussion would be in gynecology. For example, if they've seen a case of a complex stage 4 endometriosis and they want to send a case-based discussion ticket, then that can be done. And the quality assurance of that ticket obviously depends on both the trainee and the trainer. So what we would like is when case-based discussions are sent and the summaries is sent off, then the ticket should have enough of evidence to say that the trainee has got some learning outcomes and not just doing it as a tick box exercise. Then moving on, we have mini clinical exercises, and this could be a short procedure. It could be, for example, an inserting a Mirena device, or it could be taking a smear, for example. I'm just citing examples for you to appreciate how these work-based assessment tools are sent. Then the next type of example is objective structural assessment tools, and these are formative and summative. So in terms of the examples for this type of a ticket, I would like to cite the most common example, which is to do a forceps delivery. For example, if it's a lift out in the room or if it's a trial in theater, then the doctor can send an OSAT, which is either formative and summative. So summative means that the trainee is fit to practice and he or she has got enough confidence in conducting the procedure in a safe manner, and also demonstrates that there is not only competency but also confidence in managing that situation. So a summative ticket, the matrix would say that we need, for example, 3 summative OSATs to say that Dr. X is competent in forceps delivery. So these numbers are defined in the training matrix. Now the college has done a huge piece of work with the new e-portfolio, and we are now less pedantic about numbers, but we're looking at the quality of the evidence within these tickets, and that is how these OSATs work. Other examples of OSATs would be all the surgical procedures. For example, if there's a diagnostic laparoscopy, or if there is an intermediate level diathermy to endometriosis or an ectopic pregnancy, then a summative OSAT can be sent off. Another example is a preterm C-section or a full dilatation C-section. So moving on, we then have another type of assessment, which is non-technical skills, and these are called as NOTS assessment. So the NOTS assessment could be done in the context of a labor ward, or it could be done in a theater setting or in an outpatient setting. And to cite examples of NOTS on the labor ward, it is the non-technical aspects of the doctor's training. And this includes very fine domains like using handover with the help of an S-bar tool, which is situation, background, assessment, and recommendation. How does the trainee communicate with the midwifery team leader? How does the trainee, for example, delegate responsibilities? Is there a red flag system for the labor ward dashboard? And how does the trainee lead the ward rounds or delegate responsibility to juniors, and how they're stepping up to the registrar level? And this is a very important skill whilst working in the labor ward. And for MTI doctors, I must say this is very important, because our own experience with MTI doctors is that they're quite surgically skilled to do C-sections, but the main areas where they're deficient is the skills to conduct a safe instrumental delivery, communication skills around an instrumental delivery, a repair of a 3rd and 4th degree tear with appropriate identification of anatomy, and conducting all the responsibilities as stepping up at registrar level. Those are the ones which we find that the MTI doctors find really challenging. And this is a deal breaker for the MTI training program, because if they can't step up within 6 to 8 months, it creates a sense of anxiety and frustration, not only for the MTI doctor, but also for the consultants and trainers. And that is why we have tried to make sure that the assessment and the recruitment of MTI doctors is to select those with excellent communication skills who can adapt well, because they have only 3 to 6 months before they step up to the registrar level. And there is a very high level of litigation in the UK. So consultants need to feel reassured that the MTI doctor can be left alone to do a category 1C section or a straightforward lift out instrumental delivery in the room. So unless consultants have that confidence, they will not allow the MTI doctor to step up to the registrar or the middle grade rota. And this is something which we need to be very clear about. And we try very hard to support these MTI doctors to gain the skills required around instrumental deliveries and also around the NOTS, which is the non-technical communication skills. So in theater as well, that's another example where we could use a NOTS assessment, and that includes communication at the time of pre-op assessment. How does the doctor communicate? Does the doctor come on time and document everything in the notes, checks the consent form? If it's a gynecology list, have they thought of doing a urine pregnancy test where it's required? And leading the team briefing in terms of the WHO's safer checklists, prioritization in theaters, how do they manage troubleshooting in theater, and how do they communicate? For example, if it's a laparoscopy case, it's an ectopic pregnancy, is there good effective communication with the anesthetist and with theater staff? So those are the kind of aspects which are assessed in the non-technical skills. And then we have team observations. So with team observations, we would expect at least, at the very least, one set of team observations per year. Pre-COVID, it used to be 2, but the college has now relaxed its stance a little bit because of the COVID pandemic. But the reason we say 2 assessments per year is that if the first set of team observations are not good, then there is time to reflect and improve. And the second set of team observations then can demonstrate improvement. So the other thing which we find that MTI doctors find is the cultural shock. Many of them have not been ever challenged by midwives. They come from countries where they're not questioned by nursing staff, and that's a cultural shock which they face. And it takes a little while for them to get used to it, because the midwifery staff are quite a powerful lobby on the labor ward, because they are practically running the show, and they would want medical staff to come in only when they require intervention. And that's another thing which is a new concept, because in some countries there's a lot of medicalization of obstetric care, and that doesn't happen here in the UK. What they want is just to promote normality of childbirth and to keep it as normal as possible. So there is low and high dependency labor ward in many units. And in low dependency, it's entirely midwifery led, and they will not call doctors. And to cite an example, I worked in Turkey, and there used to be a midwife who used to do 1-2s as well. So we have midwifery 1-2s practitioners, and we have a high percentage of home births in many parts of the country in UK. So this is a little bit of a cultural shock for many doctors who come here, and it's a new kind of a concept which they need to get used to. But if they are able to articulate well with the midwifery staff, then they actually have a good professional rapport. And actually, they don't get challenged if they make sensible decisions. So in order to make sensible decisions, they need to know guidelines and protocols. When do you start oxytocin? Can we start oxytocin in the second stage of labor, for example? And those are the kind of challenging situations where you can have a slight disagreement between midwifery staff and doctors. And if they have good idea of guidelines and protocols, and they liaise with the consultants, then they can step up in a nice manner. Another type of a work-based assessment tool is reflective practice. Now, reflection is a GMC requirement, and many of us do not reflect very well. It is just having some insight and being self-critical. If things have gone wrong, it is really important that we have something called as a duty of candor. We're honest and transparent with patients. And that's another concept which we have to get used to when we work in the UK. And it is a GMC requirement that we all develop our reflective practice. Even as consultants, we are expected to reflect on difficult cases when there are complaints or where there are compliments. Then we have something called as DATEX, which is an incident reporting form. In some hospitals, we have POSIX. In the hospital where I work, even positive events, we do get an email complimenting that things have been really managed very well in this challenging case. So that's all about reflective practice. The GMC website is a very good resource for understanding the different models for writing good reflections. Now, I'll just talk a little bit about labor ward skills, which I've alluded to in the previous slide. So we have talked about the SBAR handover, which is situation, background, assessment, and recommendation. Now, in gynecology, most units would have a written or an electronic handover. In obstetrics, it's usually quite dynamic, but the antenatal ward, there may be some hospitals which have a written handover, but the dashboard on labor ward is what MTI doctors need to get used to. And they need to communicate with women and partners. Another example is talking with women in labor, which itself is heightened anxiety. And we have some patients or some women who really want to know everything. They want to know about the risks and the benefits. And we have quite complex discussions when there are situations such as extreme preterm labor, role of CTG in preterm labor, role of magnesium sulfate, or a C-section in preterm labor. These are really complex situations where we are potentially prone to litigation, and therefore consultants would be around to support MTI doctors to learn how to communicate with these women in such complex situations. So they would be asked to observe for the first couple of months and then step up slowly. Documentation is really crucial for obstetrics and gynecology, and for that matter, any hospital-based practice or even in the primary care. So we are very pedantic about what is written in the notes. Is it contemporaneous? Is it written retrospectively? Has it been signed? Is there a GMC number, for example? So those kind of aspects are important. Ctg interpretation, very good skill. And it just takes a long while to get used to Ctg interpretation, but that's a very good skill. And that's really a very important stepping stone for them to become registrars or work at the second on-call tier. So I've kept using the word registrar, but I must say that it is a slightly outdated term now, and we tend to use the word second on-call tier or first on-call junior tier. I've talked to you about the skills which are expected in the MTI post in the first 6 months to a year. And these are the obstetric skills which are important on labor ward. We would also ask the MTI doctors to complete some audits, guidelines, and protocols or standard operating procedure. This is always good for their CV in whichever hospital they work. So they try to improve their CV. In many hospitals, we have journal club presentations where they learn to critique a scientific paper. They are encouraged to engage in local research and complete the good clinical practice course. For example, I have been a PI for 2 research trials here. So I make sure that the junior doctors take part in delegation. And it's a good opportunity for them to gain exposure to research. And writing a scientific paper will be fantastic. It's a very great target. It may not be easily achievable, but that is something good to set as a target for the future, and also contribute to local teaching. So these are all the different types of skills which they can improve their quality improvement project portfolio. So I've got one slide on Ctg training, and that's a really important aspect of obstetrics, as you would appreciate. We have some electronic software like the K2 fetal monitoring in many units in the UK. In many units, we're now using physiological interpretation of Ctg, and therefore the FBS rates have gone down dramatically. And I must say, the last FBS I did was 3 or 4 years ago. I haven't done a single FBS last couple of years, because we are now entirely relying on the physiological interpretation of CTG. So we think about any signs of fetal hypoxia, gradually evolving fetal hypoxia. We're using terms like cycling, tachyphylaxis. These are terms which you will learn on the job, and the MTI doctors are encouraged to learn about these terms. We're quite liberal about changing positions when it comes to abnormal CTGs, giving fluids or use of terbutaline in many units. But having said that, I must say that there are lots of units in the UK which still follow the NICE guidelines and still conventionally do FBSs. So I'm not trying to say that physiological interpretation is universal across all hospitals, but this is something which is encouraged, and it is something which is going to be there for the future. The college is doing a big piece of work on CTGs as well, but this is just for everybody's information and understanding. Apart from that, we have skills drills and human factors and newborn life support and basic life support. So these are important aspects of mandatory training as well. And I've got one slide on advanced skills. So in terms of what areas trainees can get more specific experience is minimal access or endometriosis, oncology, labor ward or labor ward lead role, and maternal and fetal medicine, urogynecology, and colposcopy. Now, will all MTI doctors get to do ATSMs? No, they can't, because there are time constraints, and we have to be realistic about what the 2-year program goal is. So we can't say that MTI doctor will come in, walk into hospital and get to do complex work in endometriosis. So we have to be very realistic about it. That's not going to happen. What we're looking at is the training matrix of the 2-year program. And if they have excellent progress, if they have already passed their part 3, then a few of them can do these advanced training skills modules in an area where they would like to gain more understanding and skills and carry back to their home countries. So I must say that the COVID pandemic has created a significant challenge on surgical specialties, and those trainees with a training number also are struggling to get surgical experience. I don't know how the situation is in other countries, but currently that's a huge pressure on us, especially those trainees doing their surgical skill modules. Examples are urogynecology or minimal access, and that's a big problem for us. So health and well-being is really so important, and I know we have talked about BME risk factors, but every doctor gets a BME risk assessment. They're working under extreme challenges, and they do need to feel well supported. So simple things like health and well-being and just making sure that they're all vaccinated is so very important for us. And that is the role of the college tutor. So every unit has got a RCOG college tutor who is responsible for pastoral support and signposting these trainees for help if required. So I'll just talk. Yeah, sorry.
No, just a little conscious of time. So
yeah, this is my last few slides. So appraisal.
Okay,
thank you. So appraisal and revalidation is a trust-led process. And again, this is done on an annual basis. I'll just now hand over to my colleague Jafar Shakir, just for a few slides.
Hi, my name's Dr. Jafar Shakir. I'm a senior house officer at James Cook. I just wanted to talk about the experiences that we've had as junior doctors during the COVID pandemic. As you can imagine, it was quite difficult for me. I started off, 4 months into my medical career as a doctor, and the pandemic hit while I was in the obs and gynae department. And the cases started rising, and we had conflicting information from, government officials kind of not knowing how to manage this as best as they can. They try to protect us in the hospital as much as they can with these BME risk assessments, especially finding people who are high risk. And they were categorizing us into whether we're high risk individuals or low risk. And, the rules were basically in the air at the start, which is why we were so affected, where anyone who had any symptoms would be self-isolating for 2 weeks. And this caused a very, very heavy strain on departments. We lost a lot of doctors to self-isolating, and it means doctors being pulled from other departments to work in fields that are a bit more difficult and a bit more different to what they are. As you can imagine, being a doctor for only 4 months and then being thrown into the pandemic, it's difficult. And it's not often just difficult about yourself, you wonder about your family as well. The stress isn't just for yourself, it's for your family. I live with my mother and father, and my mother is considered high risk, so she was advised to be shielding. So it meant that I couldn't go home due to this pandemic, because you can see a patient and the next day you find out they were COVID. You have that fear inside you that you don't want to go home just in case something bad happens, or you infect your family. We didn't have much testing at the start, which is one of the other issues that we now, thankfully, we've got a lot of PCR testing where if you have any symptoms, you just go straight and get your PCR test. I think, as Mr. Rao said, there's a lot of mental fatigue as well with this, because, you're working in a pandemic where you have to be careful and vigilant at all times, as well as trying to focus on your training program and your sign-offs and everything. And obviously, this was something that was affected quite a lot. Things like case-based discussions, like Mr. Rao discussed, and mini KEXs, they were affected a lot because everyone was more focused on the pandemic rather than the actual, numbers that you had to collect. For me as a foundation doctor, we had a leniency by the foundation school by halving the amount that we needed, because they knew it was difficult to get a consultant and discuss, case-based discussions with them. They even stopped us from rotating from our original rotation just to avoid the whole headache of inductions. So everything kind of went into emergency mode, but we all pulled together. That's the good thing about this. I feel like it increased morale massively. So there are some positives actually to this, as ironic it is, as positives to the COVID pandemic. First of all, we had extremely good hand hygiene. Everyone was much more vigilant with their hand hygiene, washing, alcohol disinfectant, and then the donning and doffing. We were taught this as a skill. I wasn't taught this prior to coming into being a doctor, and I learned this because of the pandemic. And everyone was much more vigilant about infection control. But the other thing that I'd have to say is that we felt more like a family because we were facing a pandemic together. Everyone was helping each other. So if one area of the department was not that busy, we would go help out the teams that were in the other department that was busy. So we felt like we were all in this together. And the other positive is that, as this talk is, if it wasn't for the COVID pandemic, I wouldn't be able to join Zoom and meet everyone, who's wonderful and specialized from all around the world. So over the internet, teaching has become a norm now, and it's helped a lot of us because you can see, conferences that are going on in America that wouldn't normally be broadcasted, or conferences that are going on in India that normally wouldn't be broadcasted. So we have had some difficulties, but thankfully we've been managing to get through it, and the time is improving.
Perfect. Thank you, Jafar. And thanks very much, everyone, for giving us this opportunity to share our views. Thank you.
Thank you very much, Sanjay. That was really a very extensive and clear orientation to the MTI, because there are a lot of questions that people have around the MTI program and why they don't get it when they apply, etc. So I'm sure there'll be questions. But in the interest of time, we'll move on to Sue Ward's talk and then take all the questions in the end. I hope that's okay. Yeah?
Thank you, Uma. It's a pleasure to introduce Ms. Susan Ward, RCOG Vice President for Education. She's a consultant obstetrician and gynecologist working in Nottinghamshire. She's one of the very few who has been trained in surgery as well as in obs and gynae. She has been involved in medical education for a long time. And in fact, she was my clinical tutor and the training assessor when I worked with her in Mountfield years ago. Those were the days of RETA, where we had the record of in-training assessment and we had all these TO1 forms and TO2 forms. And she was in fact instrumental in making me move over to the next level of my training. With this passion for medical education, she has played a major role in the DRCOG and MRCOG exams. And with the pandemic, the MRCOG exams have also suffered to an extent. And Ms. Ward will update us on the college plans for the exam in the near future. Over to you, Ms. Ward.
Well, thank you very much for that lovely introduction. It's very nice to see you again. Pity it's over Zoom and not in person, huh? Right, so let me just see if I can share my screen. Where are we? Now, that looks quite hopeful. Can you see my slides? Brilliant. Let's see if they move. They do. Great. Right, we're in business, technically wise. So hello, everybody. Thank you very much to the organisers, especially Bhaskar and Uma, for inviting us. It's the middle of the afternoon here in the UK, and I've asked somebody else to do my antenatal clinic while I come and talk to you about exams during COVID. So we'd only just moved into this lovely new building that you can see on the slide before the COVID hit. We'd only been in there a few months and we're just beginning to plan the part 3 exam when suddenly everything went square shaped, I think. Now, you guys absolutely know that over half our fellows and members are working outside the UK. So for us, the exams overseas are quite an important part of our work stream. And I didn't know actually until I looked it up on the college website that the exam actually dates back 90 years. That's quite something, isn't it? I sat my exam about 80 years ago, I think. Well, it feels like about 80 years ago. And some of you, most of you who are involved with the college will know that we changed it substantially in 2016 from being a 2-part exam to a 3-part exam. And I just thought that I'd put that in case there's anybody on the meeting who was unaware that now the part 3 has replaced the old part 2 oral assessment. So once you've got through the part 2 written, you can bank that and you don't have to sit it again if you don't get through, you don't have to do the written exam ever again. So when did we last run in real terms before COVID? Well, that was the part 1 and the part 2 in February 2020. It seems like a whole lifetime ago now. And these are the countries in which we ran those written exams. And so we sent out invigilators with written papers all over the world. And some of you would have helped us to invigilate in India. I know you did because I was there with some of you. Now, I thought you might be interested just to see how many candidates there were around the world for those written exams. So 1,837 sat the part 1 before COVID and 2,306 sat the part 2 in one sitting, and the pass rates are down there at the bottom. And then all of a sudden we found that we couldn't run the written exams for quite a few reasons. First of all, our exam halls would not allow for social distancing. In some countries, you weren't allowed to travel anyway. The UK was locked down. So complete chaos in terms of the written exams. Some of the candidates weren't able to get to the exams anyway. As the previous speaker has just said, a lot of them were redeployed to other departments. And our invigilators could no longer travel overseas. So even if we could have got the papers overseas, we didn't have people from the UK who could go. The college was shut down. All the staff have been working from home up until last week when we reopened the college. So we had to come up with a different plan. And luckily, the plan was already cooking. So we had thought over the last few years that it would probably be better to be running our exams in a digital format because there is a security issue with sending papers overseas and getting them back. We were worried about papers going missing in people's hand luggage and that sort of thing. So we had actually been out to tender for a company to help us run the exams online. And this was nothing to do with the pandemic. We were just planning it anyway. And we had chosen Pearson VUE to do this, mainly because of their footfall. They had exam centres in a lot of countries, and it suited our MRCOG requirements because we have got so many people from overseas sitting it. And they looked quite experienced as well. So we thought they could probably do this safely for us. So what we had to do basically was speed up the signing of this contract And I'm really glad that we had started this in advance, because the rest of the world suddenly started looking for providers of online exams. So it's just as well that we were ahead of the queue here, because otherwise it could have been up to a year before we could have arranged to do our exams again. Now, we chose to use the Pearson VUE examination centres rather than have the candidates sitting at home, which is called remote proctoring, because we thought that was more secure. So we visited their exam centres abroad and in the UK. We could see that they were COVID safe. There are a lot more of them than we had exam centres previously. So we realised that quite a lot of our candidates wouldn't have to travel quite so far to sit the written exams. There was likely to be a centre in a major town near them. And certainly in the UK, we have 20 odd centres, so that's worked out quite well. Now, apart from you're sitting in a Pearson VUE centre rather than a medical school or a hotel, the rest of the arrangements are just the same. You have an ID check on arrival with photo ID, and that has been a bit of a problem in India sometimes, because people quite often have photo ID in a different name from the name with which they registered for the exam. So if you've got candidates in your hospital sitting our written papers, it might be worth mentioning them that they've got to be very accurate with their ID. And if it doesn't match up when they arrive at the exam, the Pearson VUE staff won't let them in. And the college is not there in person anymore to sort out problems like that. They've got lockers in the exam venues where you can store your electronic equipment, and actually everything is confiscated, from watches to phones to any sort of digital device, because obviously it needs to be as secure as it was in the written format. Now, the big problem we've had during the pandemic is that Pearson VUE had to distance the candidates. So they've only been able to fill every other seat in the venue, and that has caused us some problems with capacity. So whilst we were able to run the exam, we didn't have as many places as we would have liked. And so, for example, actually, I'm going to skip over that because that just tells you what we've written on the website. We've just changed the details from 2 written papers to 2 computer-based papers. But when it came to the September exam, we were able to run it in all of these countries. But in terms of capacity, we had nearly 4,000 people wanting to sit the exams, and we only had 2,000 seats. So this provided a bit of a problem for those candidates who had obviously not been able to do the July exams because of lockdown, and we didn't have enough places around the world. So we decided to put an extra exam on. So we've now run the part 1 and the part 2 in September, January and July. So going forwards, I think we probably will be sticking with the 3 exams a year format until we've got rid of the backlog. Now, as COVID eases and the social distancing rules ease in various countries, we will be able to open up all the places that we thought we were going to get from Pearson VUE. And the countries where they've had to lock down completely, again, the Pearson VUE centres should be opening up. So this should get easier within the next year or so. But certainly for 2022, we're talking about running 3 exam diets again. So January, fewer centres, and this is because of lockdown rules within the countries involved. So for instance, in Northern Ireland, they suddenly locked down over New Year, and we had to cancel the January exam there at virtually no notice, which was quite upsetting for the candidates. And of course, they couldn't travel because of the lockdown rules. So in that exam in January, the number of candidates is down quite a lot. So instead of having 2,000 odd in each exam, we had less than 1,000. So you can see the sort of capacity problems that we've run into. I also put at the bottom here what the pass rates are for your candidates, and you can see that your homegrown candidates are quite good at the part 1. So they do better than the people sitting in the UK and the rest of the world for the part 1, because they know their anatomy, they know their physiology and pathology really well. I think what they need help with in terms of running courses, and coaching is the part 2. And their pass rate is lower, just slightly lower than the rest of the world. But clearly, because it's a UK exam testing, UK practice, this is more of a challenge to your candidates than the basic sciences, which they know well. So on to the part 3 for a few minutes. Now, in the 2016 changeover, when we changed from the part 2 OSCE to the part 3 OSCE, we made some fundamental shape changes to it as well. We increased the number of tasks to 14 instead of 12, and we took away the prep stations, which some of you will remember, where you read some clinical information or an audit or something like that, and then in the next station the examiner would ask you about it. Those have gone, so there's something to do at every station now. And the reason we did that is that there are 14 bits to the curriculum, so now there is a station or a task to match every bit of the curriculum, and I'll show you on the next slide what I mean. Now, we've cut down the number of minutes that the candidates spend in each task from 14 to 10. So it is actually almost the same length of exam as we had before. It is quite exhausting exam to go round a circuit, but the minutes reading time has increased slightly more because there's more clinical material on some of the stations. Now, the other thing that we've done is to introduce lay examiners, which is a new concept from 2016 onwards. Now, these are people who are not doctors. Some of you will know a lot about this already because we've recruited quite a lot of lay examiners from India, and they're actually assessing communication skills and information gathering. They're looking at the candidates from the point of view is what do they think of them as a doctor. So there will be 4 stations in the new part 3 where there are 2 examiners at the stations. There's somebody marking the clinical material and there's somebody marking the what are they like as a doctor question. And that's a new concept that our candidates have to get used to. But it does mean that we've got rather more examiners involved in each diet. So it's quite an expensive exam to put on, the part 3. So these are the 14 bits of the curriculum. So any candidate going into the part 3 will know that there is going to be a station on subfertility, there's going to be one on the management of labour. So this is what the topics will be. Now, interestingly, and I'm not sure they all realise this, is there is a teaching task as well, where they're having to say, teach a junior doctor how to put in a pessary, or it might be teaching them how to do a forceps delivery. Anyway, it's something that you can do in 10 minutes, which could relate to any of those stations, but they're looking at the teaching skills. So if you're preparing somebody for the part 3, a really good thing for them to do to prepare for it is to teach your medical students and teach your junior docs and try and hone those skills. So the examiners, their task has changed quite a bit as well. Instead of having a tick list now with key words that the candidate has to say, we're now marking them in different domains. So we've put quite a lot of time and effort into training the examiners. And if you've been to one of the examiner training sessions, you'll notice that we're training the clinical examiners and the lay examiners together. So everybody's singing from the same hymn sheet. And it's been quite interesting trying to rewire your brain to examine the new part 3 compared to the old part 2. Now, the other thing I was going to say is that if you've been through that training, you will know that we do quite a bit of unconscious bias training as part of that day that we spend with you. And I think it's more about knowing that it's there on the table. It could be an issue. And when you're an examiner, if you realise that unconscious bias is a possibility, I think you can then take steps to try and eliminate it. So we do have unconscious bias as part of that training. Now, when it got to the end of last year, and we've been locked down for quite a few months, we realised there was no way we could pull all those candidates to the college and do the part 3 in the old format with these little booths where they go round from booth to booth reading information on the outside. And suddenly the R rate went up to about 2.7 in London the week before the exam. And basically we were told we had to cancel the part 3 in November. Now, you could imagine this caused absolute havoc. The candidates were really cross with us for cancelling it at short notice, and we held a webinar with the candidates that should have been on that exam, where they left us in no doubt as to what they thought about our actions. So that was a slightly difficult experience for those of us running the exam. And what the candidates asked us is, why hadn't you converted this into an online exam before? And I think that was a fair question. And the truth is that we'd spent so much time trying to work out how we were going to sit the writtens, and we hoped against hope that we could run the part 3. We'd worked out a socially distanced exam with the examiners in one room staying put, the candidates in another room staying put but connected to the examiners with a computer, and the role players in yet another room. But we weren't able to travel to London, so the sort of hybrid version was no longer suitable. So what we did was ask a firm to devise a bespoke platform to run the exam where everybody who was part of the exam was at home. So the candidates were dialing in from home, the role players were in their homes, and the examiners were all in their homes too. So this was quite a big ask to connect all those people remotely into the exam. And what we did was we employed enough of the college staff to accompany each candidate round the circuit remotely. So if their connection went out, or they couldn't hear part of the question, or they couldn't view the clinical material, there was somebody there with them who could fix it. Now that actually worked really well. And we ran a pilot in January where the candidates were actually the exam committee members. So I think that was a bit painful for them, having to be candidates in a mock exam with somebody like me marking them. It was quite an experience, but we did it to test the platform. So we ran a small exam in March and a much larger exam in May, and this platform works. We can adequately assess people online. We're watching them interact with patients who are role players. It's just like the previous part 3, but with everybody on a computer rather than face to face. We realised we had to increase the reading time a little bit to 2.5 minutes so that they could get through it all. Now, part of the problem is that we could only put 2 through 2 circuits at a time. So for a morning, we could only examine 28 candidates. Now, we've got over 1,000 people waiting to sit this exam. So in May, we ran 8 days of exams. We ran 4 in the UK and 4 overseas, and some of you in India were involved in this. Actually, it was quite nice because for the overseas exams, we had half and half examiners from UK and examiners from the locality. And it was lovely to be examining with people that you hadn't seen for ages because we couldn't go out to India. And again, it worked. We managed to get through. We had very few connectivity problems. We had to run about 2 or 3% of the tasks again, reruns as we call them, but generally we managed to adequately examine everybody. So if we're still in lockdown in November, we can do it online. We just, we can only run with fewer people per day. In the olden days, when we had the part 3 in the exam, olden days, we used to have 6 or 7 circuits run at a time. And at the moment, we're experimenting with running 4 at a time on the online platform. So the plan is to try and get through the backlog of the 1,000 candidates all over the world by running very, very big exams in November. And again, bringing in a 3rd diet of exam per year to try and help. So if you have got candidates who are waiting to sit the exam, I'd like to point out that we very quickly changed the college revision courses to online. That was quite a big undertaking because it's a big ask to ask your candidates to sit in front of a computer all day. You'll know if you attended Congress or other all-day meetings, your attention tends to wander after half an hour or so. So we've had to rehash the courses completely. What it has allowed us to do is to send out material before, so you can send out the questions that they're going to practice with and let the delegates have a go at them, and then you can send them their marks. And of course, the answers are all discussed during the course. So these are quite functional now, and the very big bonus for your candidates is that they can get onto these courses, whereas before it would have meant a trip to London, sitting in the college for a couple of days. So they've become very much more available to overseas candidates. So the Part 1 course has already got its dates sorted out. Now the people coming as MTIs, if you've got any of those, we'll already have the Part 1, and we're just sorting out the dates for the Part 2 and the Part 3 courses, and those will go on the website within the next week or so, I would think. The Part 2 courses are in 2 formats. There's the virtual course that we've been running for quite a few years now, which is over a weekend, Saturday and Sunday mornings for 6 weeks. And then there's a separate final preparation course over a weekend, which is all online. That's slightly different. That's mainly question practice. So that's all I had to say about the exams, except to thank you all in India very, very much, not just for helping us do the invigilation when the Part 1 and the Part 2 were in written format, but also those of you who have trained to do the new Part 3 with us and are now having to swallow doing it online in virtual format. I think, you know, somebody who's a bit of a dinosaur about change, this has been a bit of an experience over the last year, but we couldn't have done it without your help overseas. I'm sorry we've still got a big backlog of candidates, but we are working on it. Thank you very much.
Thank you very much, Sue, for that brisk update on the exams and how the college has adapted to the COVID pandemic. I must say that kudos to the entire team, because that entire online Part 3 system is just brilliant, and can only imagine the amount of effort that has got into it. And it's actually quite, in a way, though it's more tedious, I found it much easier to mark as an examiner on the online system as well. And I'm sure others felt the same. So thank you very much.
Thanks.
Bhaskar, do you have anything to say before we ask a few questions? Sanjay, the MTI talk also, I think, was extremely useful for candidates. We have a lot of people who apply, and and consistently second stage labor management and communication are the points where we find candidates have difficulty. Communication also can be helped along, but I think it's important for candidates here who aspire to come on the MTI, go on the MTI scheme, to understand that instrumental delivery and second stage management is something that's very important, and that's a challenge that. I think it's not a challenge. I think it's information that is useful for them to learn how to do that before they apply, because otherwise they get disappointed when they don't meet the criteria.
That's right, Uma. Thank you for that. I share your concerns, and obviously we appreciate that practice varies in different hospitals all across the country and even abroad, because there are some consultants who prefer forceps, some who prefer 1-2s, and some hospitals have a higher C-section rate. So we appreciate that there is a lot of variation in practice in obstetrics all across the world, depending on local settings. So I would just reiterate that, getting used to local guidelines and protocols and observing a few cases at the start, and just shadowing consultants and senior registrars who are working more hands-on, and just the initial 1 or 2 months of spending and close observation would help them settle down into their roles.
Dr. Sanjay, one more question.
Yeah.
There are a lot of aspiring candidates who'd like to go on the MTI, but in the meantime, while they're waiting, they want to know whether they're eligible to apply even after they complete MRCOG Part 2.
Yeah, they are eligible to apply after Part 2. Yeah, they are eligible, but they should not exceed 10 years of experience in obstetrics and gynecology. So the cutoff experience is 10 years. the reason the college has decided this 10-year limit is because they'll be coming and working at the level of an ST2, ST3 registrar. And when they finish the MTI training program, they are at the level of ST3 and 4. So if we have a person who's very experienced working at a consultant level in another country, for them to come down and step down to a lower level, they'll find it very difficult to settle down in their roles. And that is why we have just set the 10-year limit, but completion of part 2 should not preclude them from applying from the program.
So they are restricted to one hospital, isn't it?
They are restricted to one hospital because
So are they allowed to rotate between consultants so they get a good varied training?
Absolutely. I mean, they will be working with different consultants in the same hospital, within the hospital where they're employed, because it is a trust-led local appointment in collaboration with approval from the Royal College. So every MTI post within the trust has to be approved by the college and also by the deanery. They have to, the local trust has to take approval from the head of school before they appoint any local MTI doctor, because they have a commitment to ensure that they're providing the educational requirements of all the trainees within that hospital. And this includes those who are local UK graduates as well. So they, once they're employed by the local trust, they cannot move to another trust. It's entirely within the trust, but they'll be working with a good mixture of consultants. And the college tutor is a good port of call for them to ensure that they're getting a fair balance of all clinical activities within the trust.
Sanjay, the other question that people ask is about PLAB. If they have taken one step, I know if they've completed PLAB, they can't apply for MTI. But if they've taken one step alone, can they?
I'll have to just check the rules on that, Uma, but I don't think PLAB 1 would disqualify them. But if they've completed both parts, then that would disqualify them. But I can always check the rule and revert back to you by an email.
Yeah, thank you.
Sanjay, that is a bit of a issue with the GMC. It's not with the college. When you go for your GMC registration, it says that if you are set the PLAB and you failed it, then you're not eligible for a limited registration under GMC. That's what the GMC website says.
Okay.
The confusion about part 2 was that you cannot, for example, at the present moment, if you've done your part 3, you are not eligible for MTI. So
that's right.
We had migrated to part 3. That was with the part 2. If you've taken the part 2 and you've cleared the part 2, you are not eligible for MTI. At the present moment, that has changed to part 3. So if you jolly well can take the part 2 and still apply for MTI.
That is right, yeah. In fact, in my own experience, I feel if they've completed their part 2 exam, then they feel much more settled, because when they come and work in the hospital, they can just focus on clinical skills. Otherwise, the first 6 months to 1 year can be quite stressful for the MTI doctors, because on one hand, they have the exam pressure. On the second hand, they have, to step up to the registrar role. They're getting acclimatized to a new setting, and that first year can be very challenging. So as Bhaskar has rightly said, they can appear for their part 2 if they wish. That should not preclude them from, applying for the MTI program.
Sanjay, Ranjana wants to a little bit more detail. I mean, the mentor for an MTI candidate, is it assigned by the trust, or
yes,
how does that happen?
Yes, that's right. So the mentor for the MTI candidate is called as a educational supervisor, and ES allocations are done within the trust by the college tutor, and the college tutor will then inform the Royal College, so that within the e-portfolio, the name of the educational supervisor has to be identified. So that consultant will then log in meetings. That consultant will be able to access the trainees' e-portfolio on a regular basis, and they will just see how the evidence has been spread across the year. And so the consultants will be from the hospital itself, and it's usually decided by the college tutor, because the college tutor has an overarching information about the skill mix of the consultants, what the specialist interests of those consultants are, and whether they would be willing to dedicate some protected time for meeting up with these trainees. because educational supervision is time consuming. It builds into the consultant's SPA time, and it does require time, and therefore, that is decided by the college tutor.
Thank you. Sue, I had a question for you. I mean, I don't know if you have the data, but I was just curious. In comparison to the older OSCE format, to the current Part 3, how are overseas candidates faring?
It's about the same, actually, Uma. There hasn't been much change. We've obviously been keeping a close eye on that. And so have the GMC, because they really want to, when you change the exam, they really want to know what the effect has been on the candidates. So the pass rates haven't changed very much. I think one thing that we did notice during the lockdown, there were some candidates who clearly took a big hit from COVID. And I think, whether it's about the amount of time they've been able to revise. So the Part 3 particularly, the last one, I think there was a slight drop in the UK candidates pass rate. Not in the overseas one, but the people working in the UK, obviously they're in a bad place. I guess your candidates probably are now as well, because you've had a very rough time the last few months, haven't you?
Yes, that's true.
So I think there's a COVID effect, but when it changed from Part 2 to Part 3 for the OSCE, there was barely a blip in the exam results. So I think we're okay with the Part 3 exam. It looks like a robust and reproducible and valid exam. It's just very different being an examiner in it, isn't it?
That's true. That's true. Thank you. I think there aren't any more questions, so we will wrap up. I'm conscious that we have gone over time, but I think a lot of the interactions were necessary. And even though, when we put this together, we were wondering how this will go. I think we've had more than 200 people log in, and there's a lot of appreciative messages and thanks for an informative session. So thank you all very much. And thanks for making the time on a weekday afternoon and joining us. And I'd also like to thank Shield for providing us the platform to enable us to reach all the people. And thank you very much, Bhaskar, as always, for being a very inspiring and supportive All India Chair. Thanks, Ranjana, for taking the time to join us. And thank you very much, Tamar and Deepa. They're both active teachers and trainers for the MRCOG, both fellow representatives of the South Zone IRC. And thanks very much for your support, not just in this meeting, but for all the activities. With that, and thanks again to Sanjay and Joe and Sue, I'd like to wrap up the evening. Thank you very much.
Have a good day.
Thanks everyone. Thank you.
Thank
you for having us. It was lovely to see you all.
Yeah.
Thanks very much.
You, Chitra, tell us once we go off air.
All right. Okay.
Yeah.
Bye. Bye.
Yeah. Thanks, Bhaskar. Thank you very much. Yeah.
See you, Bhaskar.
Yeah, just a small announcement. So we hope to see everybody on Thursday for the next of our meetings. It's the ATN RCOG monthly webinar. It's going to be all about scars this Thursday. So please do join in for our meeting. It's between 2:30 to 4:30 in the afternoon.
Thank you, Deepa.
Thank you.